this episode of Making the Rounds, we'll be discussing normal pressure hydrocephalus, the importance of early diagnosis, treatment options, and surgical interventions. To learn more about this topic or other neurological related services provided at Banner Health, please visit bannerhealth.com/brain and spine. Making the Rounds dives into medical topics with those who know them best, healthcare providers. My name is Bridget, and I'll be your host for today's episode. If you're new to our podcast, thank you for tuning in. And if you're a regular listener, welcome back. Joining me today on Making the Rounds is Dr. Robert Bina, a neurosurgeon specializing in epilepsy surgery and restorative neurosurgery at Banner University Medicine, Phoenix, and assistant professor of neurosurgery at the University of Arizona College of Medicine, Phoenix. Thank you, Dr. Bina, for joining me today on Making the Rounds.
Yeah, thanks for having me, Bridget.
Well, thanks for being here. Dr. Bina, tell our listeners a little bit about yourself.
I am the very first neurosurgeon that is fully trained by the University of Arizona. Completed that training in 2020, then did a year of specialty training at the University of Louisville in Louisville, Kentucky, where I focused on epilepsy surgery and restorative neurosurgery. That includes everything from Parkinson's disease, essential tremor, epilepsy, and includes things like normal pressure hydrocephalus and treating some pain disorders as well.
So you're the first graduating class?
No, I'm the third, which I always say is the best. I'm from the best graduating class, but we're a class of 2013. The first was 2011 here in Phoenix.
Oh, that's exciting. Thank you for sharing with us. Well, we're excited to have you here today and really excited to share this topic with our listeners and with our community. So, Dr. Bina, can you help us to better understand NPH, which is the abbreviation for normal pressure hydrocephalus? And can you explain to our listeners what NPH is and how it differs from other forms of hydrocephalus?
So everybody's brain makes brain fluid. Hydrocephalus is a problem in in the management of that fluid. Either there's too much, or there's an absorption problem where you can't absorb the brain fluid that you're making. In most normal functioning brains, the brain generates about about a can of Coca-Cola of brain fluid every day. And in a normally functioning brain, it turns that over very rapidly. So you turn over the amount of brain fluid about 4 or 5 times a day. In normal pressure hydrocephalus, for some reason, we don't really know why, but the brain stops absorbing a small portion of that fluid and it starts to accumulate fluid. The problem is that in an older brain, that brain is no longer as elastic as in a young brain. So in a young brain, if you have too much pressure, it'll start to cause a lot of problems because the brain will shift, the brain will expand, things like that. But in an older brain, where the brain has lost its elasticity, that brain can tolerate an accumulation of fluid much better than a younger brain can. So in patients with a slightly older brain and a slightly impaired absorption mechanism, there is a buildup of fluid, of brain fluid, which leads to this condition of normal pressure hydrocephalus, or another way to think of it is slightly higher than normal pressure hydrocephalus.
What are some of the common symptoms of NPH and how do they typically present in patients?
In adults with normal pressure hydrocephalus, it is a chronic problem. So the onset of the symptoms is usually what we say is insidious. So it starts slowly. It's not usually a single moment in time. It's usually people notice changes over a course of months, sometimes as long as 6 months, sometimes years. The most common symptom is gait disturbance. So what spouses and families of patients with normal pressure hydrocephalus will say is that, oh, they're off balance, or they're falling, or they're wobblier than they usually are, or hear this a lot from the wives of husbands that have normal pressure hydrocephalus. He just doesn't pick up his feet anymore. So it's a shuffling kind of out-toeing, or kind of the foot position looks a little bit like a duck, and the feet aren't picked up. So patients are shuffling along rather than picking up their feet. That's one symptom. That's the major symptom. The secondary is loss of urinary control. So it's not usually a frank incontinence. It's usually they don't know they have to go until it's almost time to go. And then you mix that up with a little bit of gait unsteadiness, so sometimes that can lead to urinary accidents. The third is cognitive fuzziness. It's not the same as memory loss. It's not the same as what we see in patients with Alzheimer's disease or other dementias. It's more of a slowed thinking, or maybe a kind of a confusion or a fog. Many patients will describe it as a fog. People that have acute hydrocephalus, or a kind of a sudden onset hydrocephalus, or in like pediatric hydrocephalus, those people will have severe cognitive decline. They'll become somnolent. They'll have problems moving their eyes appropriately, and they'll often be severely developmentally delayed. In adults with the normal pressure hydrocephalus, it's a very different presentation.
What is the most common cause of hydrocephalus, and why is this a diagnosis that only affects the elderly?
That is a fantastic question, and I wish I had a better answer, but what I'll tell you is what we know a little bit about from studies that have been done. What we think happens is that at some point, as we age, the brain loses its ability to absorb all of the brain fluid that you make. We don't really know why that is. There's some relationship to hypertension. There's some relationship to metabolic syndromes, so like diabetes and other things. There's some relationship to in general kind of loss of elasticity. So sometimes smokers and things like that. But we don't have any one particular thing that we can say, aha, that's the reason why these people get normal pressure hydrocephalus. It occurs in elderly people, or what I like to say is patients with a little bit more life experience, because what we think is happening is that parts of their brain that are used to absorb the brain fluid, there's some scarring or what we call sclerosis, where they get a little bit hardened, or the filtering system gets kind of not as efficient with age. And that we think is the major factor in developing normal pressure hydrocephalus, but we don't have good tests for that. A lot of people, even up to 20, 30 years ago, were trying to find genetic reasons or molecular reasons, and we just still haven't fleshed any one particular thing out.
Are there equal diagnoses between both genders?
Yeah, normal pressure hydrocephalus is equally represented among everybody. It does not favor anybody.
Anyone.
So nobody. So yes, we actually have no idea about the prevalence of normal pressure hydrocephalus in the American population. The Finnish studies have some, and they suggest that it could be as high as 5 to 10%. But we don't know what it's like in the U.S. I do have patients who say, well, my father had this, my grandfather had this. So there's probably something that runs in families.
With a condition like that, it is difficult to diagnose. So can you describe that diagnostic process and what types of imaging techniques or labs or tests that are most effective in really finding that this isn't just urinary incontinence, this isn't just your husband doesn't want to pick up his feet, this is NPH?
It is a diagnosis of exclusion, meaning you have to make sure that it is not something else before we get to this, well, it possibly could be normal pressure hydrocephalus. As we age, there are any number of things that can cause us to start to have gait trouble. So the biggest reason why people see their primary care doctor or their neurologist is because they're falling or they're off balance. And then sometimes patients will come in because their thinking is slower. That's the primary reason why people come in. So the burden on the primary care doctor and the neurologist is to figure out, is this normal pressure hydrocephalus? To do that, they get a series of, they'll start with a CT scan because that is fastest. And it can diagnose whether or not somebody has something called ventriculomegaly. That's the expensive word for big ventricles or big fluid spaces in the brain. So that is diagnosed from a CT scan. And then an MRI will probably be ordered to rule out any other sort of dementing process or Parkinson's process. In the MRI, there'll be some features that are suggestive of normal pressure hydrocephalus. But the imaging alone is not an adequate tool for diagnosis. So what will then happen is if it's looking more like a potentially normal pressure hydrocephalus, the patients are referred for something called a lumbar puncture, which requires them to have an assessment by a physical therapist first. They do a whole bunch of tests. They time how fast it takes for patients to stand up, how long it takes them to walk a certain distance, how likely they are to have gait imbalance. So there's a whole bunch of different tests that the physical therapists do. Then the lumbar puncture happens where a needle is inserted into the spinal canal and somewhere about 30 milliliters of fluid is drained. And then they repeat those physical therapy tests within 2 hours of the lumbar puncture. And if there is improvement to a certain level, I would come into the picture.
And so when we're talking about fluid on the brain, those imaging tools don't show fluid?
They show fluid, they show that ventriculomegaly, but there can be any number of reasons why the ventricles are big. Sometimes the MRI will show that there's an obstruction. Sometimes the ratio of brain loss to fluid gain is due to a dementing process. So that's part of the diagnostic conundrum, is that there's no real picture that says, aha, this is 100% NPH all the time.
What I'm hearing and what you're sharing is diagnosing NPH is really a challenge. And can you share with us what are the primary challenges when we're going through this entire diagnostic workup that takes time? And the patients have these symptoms. How do you differentiate it from some of those other neurodegenerative diseases like Alzheimer's, Parkinson's, dementia?
It's really, really difficult to do, and that's part of the gray area for normal pressure hydrocephalus, is that even if we put in a shunt, even if we end up doing a surgical therapy, we don't get it right 100% of the time. And that's where the art and the experience comes in. Is some patients will come in and they have, they'll have a gait problem, they'll have urinary problems, they'll have memory problems. And sometimes they have all three and they don't have normal pressure hydrocephalus. I always tell patients I wish there were a different answer, but the problem is not a normal pressure hydrocephalus problem. Sometimes it is an underlying dementia. Sometimes it is due to an atypical presentation of Parkinson's. Sometimes it's due to something else, and we just don't know, which is why I really encourage patients to keep in contact with their primary care doctor and follow up with the neurologist after the shunt is placed, because that if it turns out that they're no better, then we got to keep looking.
if a patient's with you and it's like, well, I don't know if I really want to do this. If we don't really know that it is NPH, what other treatment options are available here at Banner Health, Banner University Medicine?
When there's some question about whether or not it's NPH or not, what I will often do is recommend that we call it an extended lumbar drainage trial. We bring a patient into the hospital, we place a needle in their back, and we put a drain in that's semi-permanent. So with that drain in, we can drain fluid out over the course of several days, 72 hours. And then we have them assessed by the physical therapist every day to see if they're actually objectively improving. I don't use that therapy very often because it's a pretty big commitment, but it can provide some clarity in the ambiguous patients. I would say probably 50% of the time we end up putting in a shunt, 50% of the time we end up taking out the drain at the end of the 3 days and saying, well, we know it's not this. We know we have exhausted all possible therapies short of putting in a shunt and waiting and seeing. But what the data shows is that about 70% of patients that get shunted for a presumptive diagnosis of normal pressure hydrocephalus see improvement in their gait scores. The data on cognitive improvement and urinary control suggests that only about a third of patients see improvement in either one of those. But some people will see an improvement in all three of those syndromic domains.
Is early diagnosis important with this condition, or is there really such a thing as early diagnosis for NPH?
So we don't know, and that's what's really odd about this particular syndrome, is that every once in a while somebody shows up and they have an acute decline in gait. So sometimes it is fast. I think that it is a heterogeneous syndrome, meaning that there are different subtypes of patients, and that nobody's really teased out which subtype is which and who will respond and how quickly they present, or nobody's done that work yet. And that's part of what one of the things that we're trying to do here is tease out who needs to be shunted immediately, who needs to be treated, who do we have a little bit of time for, who should we not treat because it won't help.
What advice would you give to primary care physicians and or neurologists or physical therapists that have received these referrals and that are treating these patients that they may feel, I don't know, could they benefit from a referral, to an NPH specialist?
Like we were taught in medical school, is have a broad differential. So keep it in the back of your mind. And then if NPH is becoming more and more likely, send along. Having it treated well and having it diagnosed well and having gone through all of the diagnostic workup first usually helps patients in that they don't have to go back and repeat. They don't have to get an MRI done before seeing somebody to talk to about having a shunt placed. There's a lot of information on the internet and people read a lot, and families come in and they just want they want the patient to be better. And so patients will come in with Alzheimer's and memory decline, and we put a shunt in and they improve the gait, but the memory doesn't get any better.
Yeah.
And that becomes really problematic for families because that's very distressing. But if their gait problem is actually an Alzheimer's gait problem, it can be difficult in the beginning to distinguish from a normal pressure hydrocephalus gait. It's very complicated.
So we need more neurologists?
We need more neurologists. Ideally, the way we would love for it to work is that somebody with a gait disorder who has a CT scan that shows that they have big ventricles is sent to a neurologist at the Normal Pressure Hydrocephalus Center. That neurologist assesses them, gets them in with the physical therapist does the testing, the initial testing, does the lumbar puncture, the post-testing, and then gets them seen by a neurosurgeon all within a very collapsed period. Streamlining that down to a matter of weeks would probably make things better.
Absolutely.
Much better.
For everyone involved.
For everybody.
Yeah. The goal is to open a new center for normal pressure hydrocephalus here in Phoenix.
The goal is to make a collaborative, multidisciplinary center where the diagnosis, workup, and treatment happens in a very streamlined fashion. So right now it's all very complicated, and Phoenix is very big. It's a big city, and there are a lot of people that don't do it that don't do this workup in a standardized way. And we're endeavoring to have a standardized workup that's streamlined for patients to alleviate some of the frustration and some of the burden, because it's frustrating for patients.
Thank you for all of that amazing work that you guys are doing, and we're really excited to see where this treatment and care goes in the near future with with the center.
Absolutely.
Anything else you can think of?
The other thing is that patients will often be surprised at how simple the surgery is. Yes, it is neurosurgery, it is brain surgery, but in terms of the physiologic challenge or to their bodies to recover from, it's actually pretty simple. It's not a very complex surgery at all, and it's a very, very, very safe procedure. But helping patients understand that it's a relatively minor procedure is part of the ongoing education. That the more that I've had patients come in and tell me that their neurologist has told them that they wouldn't recommend it for their mother because it's such a dangerous procedure. And then I told them, no, this is very simple. And we actually, I've had patients wait years and years and years because they've been given misinformation by a neurologist about how dangerous the procedure is. So just kind of clarifying that it's a simple procedure, and patients do really well with it.
That's great to hear. Dr. Bina, we can't thank you enough for being here today and sharing your expertise with us. And this is not an easy diagnosis. None of these neurodegenerative disorders are. So thank you to you and your team for all the amazing work that you guys do for our patients here in Arizona.
Well, thanks, Bridget. Thanks for having me.
Thank you for joining us today. If you found this conversation as informative as we did, please subscribe to our podcast for more discussions on important medical topics. To learn more about Dr. Bina and the neurosurgical services provided at Banner Health, please visit bannerhealth.com/brain and spine. Thank you for listening, and we'll see you next time on Making the Rounds.